Good morning, good afternoon, and good evening to all those joining us from around the world. My name is Dr. Sanjeev Silva. Welcome to this very special Christmas 2020 webinar, which will see Sapien Care Group into 2021. So a lot has happened since our last webinar on vaccines during the summer. Back then, it was incredulous to most experts to think that we would have multiple viable vaccines delivered to the world by now. Based on phase 3 data that is barely published, most vaccine contenders have been given the emergency green light approval. It is a testament to humanity in facing a global challenge of this nature, together both in developing a vaccine, but also delivering it to patients worldwide. There have been thousands of mutations around already from the original Wuhan COVID-19 RNA sequence that was first published. But the most recent UK announcement of the mutation N501Y, where one sole amino acid has changed at the 501st position of the spike protein, has changed the shape and made it more contagious. So asparagine N at the 501st position has been converted to tyrosine Y. And we believe that's started back in September in Kent. This is important as the change has been on a receptor binding domain of the virus, which now latches on more efficiently onto the ACE2 receptor on a human cell. Therefore, it makes it far more transmissible. So the protective vaccine and the tyrant virus are now in a race against each other to get to the most vulnerable in society. It's inoculation versus infection. And the next few months are going to be a very telling time for the time period for the world. So I'd like to hand you over to our very special chairman of Sapien Care, Professor Stafford Lightman, Professor of Medicine at Bristol University, who will introduce our very special panel of guests who are joining us today. Thank you so much.
Thank you very much, Sanjeev. And I'd like to welcome you all to our Christmas seminar. I should like to welcome both our regular Sapien Care webinar viewers and our new attendees. This webinar, as Sanjeev says, comes at a truly critical time when COVID's surging in many parts of the world, and we're anxiously grappling with the possible significance of the new strain, which may have increased transmission efficiency, whilst at the same time, we're beginning to roll out new vaccines in a limited number of countries, and for which there's only currently limited manufacturing capacity, and for which global distribution seems a distant wish. There are a lot of questions for our expert panel, not only with respect to vaccination itself, but also what should be the goals of vaccination? Is it herd immunity or just protection of high-risk sections of the population? How do we all, and GPs in particular, deal with vaccine skepticism? And do we as a society believe it's actually a duty to accept vaccination to protect others rather than just protect ourselves? These are just a few of the many questions which are likely to come up this evening. Fortunately, we've got a superb panel of Jerome King, Roger Henderson, and David Lidington to help us shine a light on these issues. And so to start off, we have Jerome Kim, who's joining our webinar series for the second time. Dr. Kim is Director General of the International Vaccine Institute in Seoul, South Korea, and Professor of Medicine at the Uniformed Services University of Health Sciences. Jerome, would you kindly start and provide us with an update on the current state of vaccines and their potential to provide a way forward? Jerome.
Thank you, and it's my pleasure this morning, or this evening in the UK, to speak to you today. All right, I'm going to go briefly through these slides, and there'll be time for questions. So I apologize if I'm going rather rapidly through a lot of information. Oops. Claire, I don't seem to be able, oh, there we go. So after 11 months in the darkness, the day of efficacy is here. Here we go. But we made progress on the first, only the first of 3 hurdles. And I think as Sir Winston Churchill said, this is not the end, nor the beginning of the end, but possibly the end of the beginning. Because after we've proven that a vaccine is safe and efficacious at 2 months, we're still going to have to make between 10 and 16 billion doses of that vaccine or those vaccines. And then we have to allocate them, distribute them logistically, administer the vaccine to 8 billion people around the world. And I think it's important to remember that vaccines don't save lives, vaccination does. Let's see, Claire, thank you. Actually, can you click through
yes, just let me know then.
Right, again, please. So, what do we have to go on? Well, you know, so far, 4 or 5 vaccines have announced, or manufacturers have announced that they have safe and efficacious vaccines. But before that, we knew that 14 different vaccines had been tested in non-human primates, that is in monkeys, and all of them had shown protection. In fact, of the leading candidates, only CanSino has not reported non-human primate protection data. You could have broken the vaccines down into 3 tiers by their what we call neutralizing antibody titer, the level of antibody or infection fighting protein that binds to and inactivates virus or prevents its entry into cells. At the lowest level, those with titers under 100 or levels under 100 are CanSino, Sinovac, and Gamaleya. So 2 Chinese vaccines and a Russian vaccine. With titers between 100 and 500, so again, we always assume in vaccinology that the higher the neutralizing antibody titer, the better the vaccine. Johnson & Johnson, which is a single dose, Sinopharm, AstraZeneca, and Pfizer-BioNTech. And then, of course, with titers over 1,000 are Moderna and Novavax. And could you advance, please? And again, please? Again, please? One more time. And the last one. Perfect. I think it's important to remember now that we have announcements. Actually, there's been a 6th announcement, but really we don't have efficacy or safety beyond 2 to 3 months. Leading the pack, of course, is Pfizer-BioNTech with a vaccine efficacy of 95%. That was followed shortly by Gamaleya with a vaccine efficacy of 92%, Moderna with a vaccine efficacy of 94%, then AstraZeneca and Sinopharm, AstraZeneca with a efficacy of either 62% if you use 2 full doses, or 90% if you used a half dose followed by a full dose. Sinopharm actually didn't announce its results. The United Arab Emirates did. And actually, in another kind of very unusual announcement, Sinovac has not announced its results, but Brazil has announced that Sinovac's vaccine worked at better than 50%. So again, we don't have anything official from the company. Next slide, please. But it's very important now, not only to prove that a vaccine works, but then to make it in significant quantity. CEPI, the Coalition for Epidemic Preparedness Innovations, believes that 2 to 4 billion doses of COVID vaccines could be manufactured annually. This means that our models are predicting that we won't have enough vaccine doses to vaccinate the 8 billion people on this planet until 2023 to 2024. But I think that one of the important legacies of this outbreak is that major manufacturers, the Pfizers of this world, the Johnson & Johnsons of this world, are actually contracting out their manufacturing. So Serum Institute and SK Bioscience in Korea are making the ChAdOx, the AstraZeneca vaccine.
Right?
Sorry. Okay. Serum Institute and SK Bioscience are making the Novavax vaccine, and Biological E is making Johnson & Johnson's vaccine. With all this being said, though, and I think as Professor Lightman pointed out in the very beginning, we still don't have enough supply. Particularly early on, there are going to be shortages. And the United States, which had already ordered 100 million doses, recently asked for 100 million more from Pfizer-BioNTech, and they were told they had to wait in line. 50 million doses could be available at the end of June, and another 50 million doses at some point after that. So you can see, even for high-income countries, everyone has to wait in line. Oh, next slide, please. Great. So for countries around the world, though, that are not necessarily high income, how is vaccine going to be made available? 189 countries have joined something called COVAX, which is organized by CEPI, Gavi, the Vaccine Alliance, and the World Health Organization. It's coordinated by Gavi. 92 low and middle income countries could be supported with free or low cost vaccine under an advanced manufacturing commitment from COVAX. They intend to have 2 billion doses of WHO pre-qualified, that is WHO approved vaccine available by the end of 2021, although that number right now is about 1.7 billion committed. This reflects roughly 20% of anticipated demand. So you can probably vaccinate the elderly and healthcare workers. Beyond 2021, we don't really know. Against COVAX is the unfortunate finding that 8.8 billion doses have already been pre-ordered or reserved, mainly by high-income countries. Modeling suggests that the exclusive use of the first 2 billion doses by high-income countries without any consideration of global equity will double global COVID deaths and will probably make the elimination of COVID-19 much less efficient. And finally, there's a question about COVAX itself. Reuters reported last week that COVAX is at high risk of failure. This is from internal Gavi documents. The World Health Organization followed that a day or two later by announcing that it had secured additional in-principle commitments of hundreds of millions of doses of vaccine. So where are we with COVAX? We're not really sure. Next slide, please. Sorry. Perfect, thank you. And it looks like a lot of the high-income countries have ordered far more vaccine than they actually need. So what you see on the graph here are the high-income countries, upper middle and lower middle income countries, and their vaccine orders. And the first line is 100% coverage of its population. So you can see that Canada's ordered about 5 times more than it needs, the United States potentially 4 times more than it needs, the UK right now potentially 4 times more than it needs, the European Union about 2.5 times more than they need. But they're not the only ones. If you look at the upper middle income countries, which have money to spend on vaccination in order to prevent COVID transmission in their populations, Brazil and Indonesia and Mexico are at nearly 100% of their current needs for vaccination. But even lower middle income countries are putting in pre-orders. Now, how this is going to affect COVAX and how it's going to affect global supply, we're not really sure. Next slide, please. Great. And I think that the thing that we want to avoid, at least from a global health perspective, is an equity gap or an access gap. And we see this, for a lot of different vaccines, what we call the premium vaccines, but let's just pick rotavirus vaccine because it's a highly effective vaccine. Rotavirus diarrhea has nearly disappeared from the United States. As a physician, as a pediatrician, trainees are not seeing it. They have to go elsewhere to see rotavirus diarrhea. This is because the vaccine was approved in 2006. Uptake was very rapid and rotavirus diarrhea nearly disappeared. World Health Organization approved the rotavirus vaccine in 2009 and recommended its use. Now, 11 years later, 60% of the world's children still do not receive all 3 doses of rotavirus vaccine. We don't want the same thing to happen for COVID-19. Next slide, please. So let's start with 16 billion doses. And how do we get 16 billion doses from the manufacturer out into the field? The world is actually fairly good at giving vaccine to children. So thanks to Gavi and UNICEF and the decade of vaccines, we are actually able to vaccinate about 80% of children with the vaccines that are normally found in the extended program of immunization. A really remarkable achievement, saves 2.5 million lives a year. But how are we going to go from a extended program of immunization, EPI, to a universal program of immunization? We're not only going to have to vaccinate those children, we're going to have to vaccinate their brothers and sisters, their moms and dads, and their grandparents. And how are we going to do that? Logistically, it's complicated. IATA estimated it would take 8,000 jumbo jets for just a single dose of vaccine to be distributed around the world. When I spoke to them about a month ago, they said, "What, equip a plane with -70? No, we don't have planes that are routinely set up for that." So again, we're going to have to think about the way we get the vaccine around the world. The other problem here is multiple vaccine formats. So you can see already, for instance, in the United States, Moderna and Pfizer are being rolled out. in other countries, how are we going to keep track of those vaccines? Who received which vaccine? This is particularly important if any of the vaccines have side effects, so that we can correctly attribute side effects to vaccines. We don't want a problem with one vaccine to take out the rest of the vaccines because of safety concerns in the general public. How are we going to conduct this? Actually, could you advance, please? Twice. How are we going to roll this out? Through campaigns, through drugstores, through work? Are we going to vaccinate celebrities like Elvis? And what do we do to people who've already been infected? There are over 500 people that are being tracked around the world who have had a second COVID-19 infection. Can most people be infected again after a certain period of time? We're just not sure. Do they need to be vaccinated? Again, not sure. Next slide, please. This is just to remind me. One of the things that we still have to do scientifically is optimize the schedule and the boost. And some people have said, well, but we already know Pfizer went through a number of different doses in order to pick the optimal dose. Well, I think that if anything, the AstraZeneca experience is very illustrative. AstraZeneca had 2 full standard doses, a full dose at time 0, followed by a full dose 1 month later, or at least a month later. But accidentally, they found out that if you gave a half dose first and followed by a full dose, efficacy went from 62% to 90%. And that's an illustration of, we actually did manage to find a number of efficacious vaccines in a very short period of time. But because the time frame for vaccine development was compressed, we often weren't able to really understand the impact of the different doses and the different schedules. So remember again that with AstraZeneca, they said at least a month apart. This meant that because they changed the schedule from a single dose to multiple doses, some of those vaccines were given at 1 month, 2 months, and 3 months. And which of those is the optimal? And again, we don't at this point know. The lower part of the slide comes from data from Sinovac. Again, they found that if they went from receiving the second vaccine at 2 weeks to receiving the second vaccine at 4 weeks, that titers went up, that the availability of neutralizing antibody against COVID-19 went up. So again, we didn't necessarily have time to optimize the dose, the schedule, and we really don't at this point know when a person needs to be boosted to receive a booster dose, 6 months, 12 months, 2 years. We hope it's longer, but we don't know. Next slide, please. Advance again, please. Thank you. If you could back up one to the correlates of protection. There is a timeline to develop what's called a correlate of protection. That biomarker, what immune response correlates with protection. This is very important because once we have vaccines that are safe and efficacious, it may not be ethical to conduct a trial with a placebo. So correlates of protection offer a biomarker analysis that may substitute for efficacy trials against placebo. What you can see here are the major developers, and the gray box that has COR in it is when correlates may be available. The good news and the bad news is, of course, that with vaccine efficacy of 94 to 95%, there aren't going to be many people in a very critical part of the correlates analysis. To do a correlates analysis, you compare the immune responses in vaccinated infected people to immune responses in people who were vaccinated but didn't get infected. And often the people who didn't get infected will have higher levels of some protective response. Let's just say neutralizing antibody. The problem here is that with highly efficacious vaccines, such as what we see at 2 months with Pfizer and Moderna, we may not have enough people in the vaccinated infected group to do a meaningful correlates analysis. So again, a potential problem. Next slide, please. Another important question has to do with herd protection. So I think a lot of people are hoping that these vaccines, once we are able to vaccinate 60 or 70% of the population, that we will achieve what is called herd immunity or herd protection. The problem is that phase 3 trials, and I believe that the number is maybe 200,000 people around the world, volunteers are participating in these phase 3 trials. They're beautifully statistically sound, They are designed to look very specifically, without bias, at whether a vaccine protects an individual against disease or infection. An individual. And what we're looking at is herd protection. And so to do that, we have to understand whether these vaccines also block transmission. And some of the trials now have a component that may help us to understand that. There was a suggestion that some people have made from the AstraZeneca trial that there may be a reduction in asymptomatic transmission. Again, is there a blocking effect? We don't really know at this point. And to do those trials, what we call effectiveness trials, to generate real-world evidence is something that we're going to have to look at very carefully in the future, particularly as vaccines are being rolled out to the general population. What you can see in the slide is just a number of different diseases, their basic reproduction number, or R0, which we've heard a lot about recently, the herd immunity threshold, and then the vaccine efficacy and effectiveness. Remember, measles vaccine is 94 to 95% efficacious. In order to achieve herd immunity, we have to vaccinate 90 to 95% of the population. Again, a reminder that this is a number that should be derived from actual data, and it's going to be important. It's important to know that 60 to 70% may theoretically be important. It's going to be very important to know how we block transmission, how we decrease hospitalizations, how we decrease deaths in the population. Next slide, please. Coronaviruses. So just a brief word on coronaviruses. So coronaviruses are promiscuous in that they can go into multiple animal species. I think COVID-19 is a great example of that. The mutation rate, again, is 8 to 10 times lower than it is for influenza. The 614G mutation, which actually swept through Europe, literally, in March and April and became the predominant strain, was very important. The UK Christmas strain, which has a different designation, it's called B.1.1.7. It has a very particular set of mutations, actually 14 to 16 of them, depending on how you're counting them. It has been spreading more rapidly since, it's been spreading since September, but particularly recently, 60% of infections in the London area have been that particular strain. Now, is it being driven by the strain or by social behaviors? And again, it's difficult to say at this point. It's something to be very concerned about. It's going to be important as we move on in the future, as we're rolling out vaccines, to continue very, very active surveillance for mutations and to determine quickly whether those mutant viruses, mutant COVID-19s, are susceptible to vaccine-induced immune responses. And again, at this point, we don't know anything about the Christmas strain that's spreading around the UK. The other part is that, COVID-19 is one of those coronaviruses that made the leap from bats into some other animal, maybe then into humans. We're going to need to look and make sure that we're not surprised by COVID-22 or COVID-24 in the future. And that means that we need to conduct worldwide surveillance, the same way we do for influenza. Next slide. And one more, please. And this should be the last slide. Yes. So again, to remind everyone, we already have 4 to 5 vaccines showing short-term efficacy and safety and should have more by January of 2021. But what more needs to be done? 16 billion doses of vaccine need to be manufactured. We need to distribute that vaccine so that it can get into 8 billion arms around the world. The other big questions, have we optimized the dose and schedule? Do we need boosts? What are the correlates of protection? When will we achieve herd immunity? Do we have adequate surveillance globally for mutations or new emerging coronaviruses? We very importantly need to follow up vaccinated volunteers for long-term safety post-efficacy. We have to figure out what to do about opposition to vaccination. And there are a number of different groups, some of them anti-mask, some of them vaccine hesitancy, and they've combined in some cases. And how are licensure and emergency use going to affect our testing of future vaccines? I think it's important to recognize that a vaccine is just a weapon in a war against COVID-19. But in order to win this war, we're going to need a comprehensive strategy for prevention and also an army of vaccinators in order to get those vaccines into the arms of people who need them. Thank you.
Oh, thank you very much indeed. Can we get back off the screen now, please? That's a fantastic introduction. I think most of the discussion we'll have at the end. There is just one thing I'd like to ask you, because it's related to this concept of possible herd immunity. And that is that should we be giving the vaccine in our state of current knowledge to children? And if children basically argue if they get the disease, they're really at very little or no risk about it. But we're also then giving them a vaccine for which we have only knowledge about 2 months or so of having given the vaccine of its potential risks. So as a parent, would you want to give your 12-year-old child a vaccine? And if you don't, there's no question of us ever getting to herd immunity unless we're vaccinating all the children as well.
Yes, that is a great question. So I think that there are going to be a couple of ways to answer this. I mean, we know that, for instance, vaccinating children with influenza vaccine appears to protect their grandparents, which is a very important point. And the same applies to pneumococcal conjugate vaccine. Vaccinating them with pneumococcal conjugate, again, protects their grandparents. For COVID-19 vaccines, though, right now we have evidence that the vaccine prevents infection or disease in individuals who receive it. We don't have evidence that the vaccine prevents transmission in the community, so that vaccinating the children at this point doesn't necessarily guarantee that we will have prevention of spread through the community, even though we think that children may be important in spreading COVID-19. So right now, focusing on what we know, protecting higher risk populations at high risk of acquiring disease, or in particular of dying because of that, is very important, because that's what we have data for.
Okay, well, there's a lot there that we need to discuss and we'll come back to later. But I'd like now to get on to our second panel member, who's Roger Henderson. Dr. Henderson qualified as a general practitioner in 1990. In 1995, he became the medical columnist for the Sunday Times. He's now health columnist for The Spectator and is the UK medical director of the health IT firm Liva Healthcare. Roger is going to provide us with a view from primary healthcare, and he's going to discuss, amongst other things, the logistics of rolling out vaccination across GP practices, and will provide insight into the ongoing nature of vaccinations and how we may need it to protect us against COVID in the future. Roger.
Thank you very much indeed, and good to be here, and thank you for everyone who's joined us. Following Jerome is always difficult, and this is no exception. So what I thought I'd do is I'd talk about 3 or 4 areas, messages from the wayside pulpit, as you were, in primary care, as I see it, for the factors that are affecting our day-to-day activities about the vaccination rollout programs, and perhaps talk about 1 or 2 things that may not have been thought of in particular, which are starting to prove slightly sticky issues. And I was going to talk about GPs and the vaccination strategy, as Stafford says, potential IT difficulties we may come across, the timescale that we need to look at, and touch on anti-vaxxers and vaccine hesitant patients. And I think David may touch on those as well. So I suppose I'll start with an obvious question. Why should GPs be doing it in the first place? Well, we are embedded in the community. We've been there for decades, and the public trust us. We know our patients, they know us, and GPs are still the most trusted professionals out there by none, and consistently stay that way. And that has some import. We have easy access. Our patients can get to us easily, and we are used to immunization campaigns. On an average year, we give about 15 million flu jabs without thinking about it. And I would argue...
Yeah, Roger.
Yes?
Sorry to interrupt. Your picture is not on.
I'm sorry. I'm sorry. 2 seconds. I'm sorry.
Yeah.
Sorry about that. The perfect face for radio. So we are used to making things work. We are the super specialists of the NHS, and we do 90% of NHS consultations for 10% of the budget. So we're in the right place and we're the right people to do it. But we are chronically underinvested and have been for the last decade at least. That's leading to a serious shortage of GPs, particularly in the over 50s, very experienced GPs. We've got overstretched teams as a result. We're swamped with work. And so if we're going to ask primary care to be central to the vaccination rollout campaign, there are things that I think we should be doing. Now, straight away, I would be saying we should be stopping CQC inspections. They are simply a distraction at this time, as are appraisals, as are revalidations. They are not needed at this moment. They do not add anything to what we are doing, and they distract us from our core work. Playing devil's advocate, if you have practices that do not want to join the vaccination campaign, and we're already seeing some primary care networks opting out of vaccination campaigns on the back of the 15-minute allergy system, where you have to get someone waiting for 15 minutes after they've had their jab to make sure they don't have an allergic or an anaphylactic reactions. That has caused logistic problems for many practices, and some of them already decided to opt out. So if you have a practice that chooses not to be involved, or an area that chooses not to be involved at surgery level, what should be the criteria you should be looking for? Well, you'd have to have large public spaces for a start. You'd have to have little vaccination wastage, and already we're seeing that actually GPs are very good at not wasting the vaccine. Staff would obviously have to be in full PPEs. There'd have to be little mixing of people, because we need volume and we need throughput to get an effective vaccination day. And to get that, you need space. Non-GPs can give the vaccination, and I think that's important, because GPs are expensive pieces of kit. It should not necessarily be the GP giving the vaccine. Other people can be doing that, while GPs are getting on with the really core, essential clinical work that has actually built up like a tsunami over the last 6 to 9 months, and which is going to spill over into 2021. You know, we are going to be swamped with that work that has been building up and hidden from us in many cases this year. So those are really why, if you're going to be in practice, that's fine, but if you're not going to be in practice, there are criteria you need to make that work. And one of the key things, whether in practice or out of a practice setting, that needs to be workable is IT. The holy grail of the NHS is to have an all-size-fits-one working primary care and secondary care IT computer network. But unfortunately, it's been like alchemists trying to find gold out of base metal. It hasn't happened in the last 10 to 20 years. We have poured tens of billions of pounds into trying to find a system that has all been wasted. And you're surely as hell, you're not going to get a system that's going to be up and running in the next 3 to 6 months. And NHS England have already said that the IT system currently in use does lack the required functionality to record COVID vaccinations under the new enhanced service in England. And we mustn't forget the old computer mantra, garbage in is garbage out. So we need to have a system that records who's had it and who gave it. That's extremely important for medical legal reasons. If you give it in occupational health settings, you have to have a system where that can be put onto GP systems. If you give someone in a care home the vaccine, who puts it onto the GP system? And the BMA have said it's absolutely essential to ensure that systems are in place that allow some mass patient notification and recording vaccination status into our GP records. And this is far more preferable, to my way of thinking, than a centralized and disconnected IT system, which has already shown limitations with informing GPs about test, trace, and isolate, for example. So we've poured huge sums of money into what have proven to be fairly inefficient private sector test and trace systems. And the currently earmarked vaccination funding is currently a fraction of this by comparison. So the IT system is something that's not necessarily automatically thought of, but the whole vaccination program will actually stand or fall by that. And I don't think that's been grasped by some people, especially people in high government. The other thing that hasn't been grasped, I think, in high power is the timescale, which is certainly currently unrealistic and has been politically driven, I suppose, and it's been on the back of optimism bias. Now, I can understand why this is the case. If you've had a year of unremitting gloom and doom, you're always looking to give optimism and to keep people going for that one last furlong. The problem with that, and we've heard this many times in recent days, is you overpromise and underachieve. And I think when the news came out about the Pfizer vaccine, it was an absolutely joyous day, absolutely fabulous. We were all thrilled to bits. The next day, I saw a patient who said to me, "Doc, oh, thank heavens that COVID's over." And that's some of the psychology that's out there. And we're still hearing people saying, well, January, February, maybe March, the sunlit uplands are there. Forget that. We should be saying it'll be summer at the earliest, and we're trying to aim for a semi-normal Christmas next year. You have to be honest with people. As Jerome touched on, we don't know how long an effective vaccination protection will last. Are we going to need to re-immunize patients every 6 months? And again, the recall system is vital here. So a dose of absolute honesty would not go amiss from where I'm sitting in my primary care desk. And I suppose finally, the COVID deniers and the haverers, and I would classify these into two groups. The extreme group, which fortunately are the fewest numbers, are the absolute COVID deniers. COVID is a myth. The vaccine is a political stunt. Bill Gates is putting microchips into your arms so you can see what you have for breakfast. And it's all completely false and made up. Now, these are the flat earthers, the people that say Apollo didn't go to the moon. Now, you can try and reason with them, but it's usually a complete waste of time and energy. The far bigger group are the COVID haverers, the ones that in their hearts think they probably should have the vaccine, but they think it's all been rolled out a little bit fast. And one of the phrases I'm hearing a lot from patients who are sensible people and would really like the vaccine, but not today, they're saying, oh, I think they must have cut corners. The phrase cut corners comes through a lot because of the speed the vaccine's being rolled out. Now, they have no idea about the normal rolling out of a vaccine over 5 to 10 years pre-COVID, and why should they? They're not fully in that loop. So you can't blame them for thinking it's being rolled out quickly, even though you and I know it's safe. But psychology is vital to win over that group. And social media is something of a curse here, because if you have one fixed viewpoint that may fly in the face of facts, you can get confirmation bias wherever you choose to look for it online. So if you've got some crazy idea about COVID and you search far and wide on the internet, sooner or later somewhere, you will find an article or a group of people who say the same thing as you. It affirms your viewpoint. And if you directly challenge that or call that denier stupid, you cause what's called the backfire effect. It firms up a viewpoint. So the point of view that you have to take is non-judgmental. It has to be empathetic. You have to take time with the patient and explain and answer their queries. And you have to be able to suggest trusted places that might want to go online and look for quality information. And we should be asking the press to make taking the vaccine a positive social norm. So we say 60% of the population have had the vaccine rather than 40% of the population haven't. And finally, it's really important to make the vaccine easy for people to get the vaccine when it becomes available. And I'm going to take you back to Yale in 1965, and a study that was done then has been forgotten about, but it was a study that looked at students getting their shots for tetanus. And when that large cohort of students were told, you need a tetanus shot, and that was it, 3% of them turned up to get it. When they were told, you need a tetanus shot, oh, and by the way, that's where you go, that's when it's open, and here's a map showing you how to get to there, over 30% turned up. Psychology is absolutely vital here. Draconian central enforcement from on high by diktat and finger wagging will not work. It will misfire. We need agreement more than ever. And as Jerome says, we're in a war. And to win a war, you need to have your troops on board. And our troops for this vaccine are the public, and we need to bring them with us. They have to be following the generals, and the only best armies that follow generals are the ones that trust their generals. We've got a lot of work to do, but there is light at the end of the tunnel. At the moment, though, it seems a bit of a long way away.
Roger, thank you very much. And that dose of realism is actually really important. At this stage, I just want to ask you one question. It's inevitable, of course, that a lot of people who have vaccinations, particularly the more elderly people, a lot of them are going to have heart attacks, strokes, and various other things are inevitably going to happen because they would have happened anyway. But there is going to be a sort of outcry that, you know, my grandfather had a stroke one day after having his vaccine. How are you going to prepare people so that this doesn't become something that takes off and becomes frightening?
That's an absolutely vital point. And I think if you think about it, as you say, every second of every minute of every hour every day around the globe, and we're trying to vaccinate the globe here, as we speak, people are having heart attacks and strokes. So by the law of averages and statistics, I will probably vaccinate someone with COVID at some point who the next day has an MI or a stroke. I think there are two things we really should be careful to do here. The first is not, when we're talking to patients about informed consent, we have to make sure it is informed. And by which I mean, it's not just talking about the potential little minor side effects we all, talk about when you're giving the flu jab, for example. It is to say that there is no evidence that this causes significant serious problems. And also to say that, as you say, common things are common, and some things can happen that are completely not to do with the vaccine. Just as importantly, and I come back to the IT system here, and again, I don't think this has been widely recognized, medical legally, even if you've done that action, even if you've given informed consent and sat down with the patient for 15 minutes, and you know that, and the patient knows that, if you have not recorded that fact in a court of law, it has not happened. And that's why you have to have absolutely crystal clear, good, concise records on any computer system that you use when we're giving this COVID vaccine. It's going to happen. There's no question about that. But if you can preempt, if it does happen, because the likelihood it won't, but that 1% where it does, if you can give such good informed consent, where you say, well, that's not going to happen, but if it did, it's nothing to do with the vaccine, you've at least built up that insurance and that defense.
Roger, thank you very much indeed. We'll come back to discuss that later. I'd now like to go on, please, to our next speaker, who's David Lidington. David was elected Conservative MP for Aylesbury in 1992. He was Lord Chancellor and Secretary of State for Justice from June 2017 to January 2018. And he was Minister for the Cabinet Office and Chancellor of the Duchy of Lancaster between the 8th of January 2018 and 24th of July 2019. David has very kindly agreed to help us understand the politics of COVID, its implications for the working of government, and how we deal with public expectations and the increasing evidence that young people are increasingly taking their own decisions about COVID regulations. David.
Stafford, thank you very much indeed. I'm going to try and keep these comments brief, and I hope that colleagues will bear with me, because there is inevitably going to be a certain amount of oversimplification and omission, given the time constraints. But I want to touch on three subjects: of public attitudes to vaccines and vaccination, some of the practical problems and the political balancing acts that governments face, and third, the particular issue of China, given that there are a number of different Chinese vaccines in development, which, if deployed globally, do have a very significant potential to affect, in a good way, the availability of vaccines around the globe. I start with the public attitudes to vaccines. My observation about the position in the United Kingdom and most of the other sort of Western democracies would be that the majority of people believe in the efficacy of vaccines, but there is a significant minority which dissent. If you look at the figures that Kantar, one of the leading polling organizations, produced from a survey in June in November this year, and then it was in June and then again in November this year, they measured attitudes in the United Kingdom and other OECD economies. In November, 43% only of respondents in the UK said that they definitely would take a COVID vaccine when one became available. That was down from 50% in June. I happen to suspect that with the surge in cases recently and the press stories about the new variant, that probably that figure will have gone up from 43% just in the last week or so. But the dissenting minority is significant, and the UK figure of 43% saying they definitely take the vaccine is higher than in most comparable countries. Italy 38%, Germany 35%, USA 30%, France 21% only, saying that they definitely would take a vaccine when it became available. Looking at the British situation again, 57% agreed with the statement that if UK national public authorities proposed a COVID-19 vaccine, then they could be confident it was not dangerous. 15% disagreed with that, and the rest was sort of didn't know enough or care enough to express a view. So you have 15% there who don't think that the NHS saying that something is safe necessarily counts with them. And it's worse if you ask them not about the authorities, but about the government. Do you trust your government to make the right decisions about a C19 vaccine? Yes. UK, again, yes, 68%. No, 32%. Really striking and alarming dissenting minority there. Only just over a third of people believe that the risk from COVID-19 is so severe that it is acceptable to take fewer precautions than usual to approve and distribute a vaccine. And I agree very much with what Roger said earlier, that while the number of anti-vax deniers who think that it's being spread by Bill Gates or G5 telephone masks or being brought in from outer space or something is tiny, there are larger numbers of people who are worried, ironically, by the very speed at which it has been developed. And I think that neither politicians nor scientists have yet been able to crystallize in the public mind through effective communication why people should still have confidence and why people should believe that no corners have been cut, which of course is about the fact that this has been a global endeavor with information being shared and cooperative working taking place in a way that we just haven't seen previously. But so the lesson of the need for strategic and effective communications, I think, runs through what I want to say. If we look again, last month, an academic study, part funded by organizations like the Nuffield Foundation and the Wellcome Trust, looked at the views of more than 32,000 adults in the United Kingdom. They found that 16% of respondents had high levels of mistrust or misinformation about vaccines, and the prime indicators of somebody likely to be mistrustful were someone from an ethnic minority, someone from a low income, or women with children. University College London, another study, a fifth of the public saying that they are unlikely to get a vaccination when one is offered. So there's a really big challenge there, where it seems that politicians and scientists and medical practitioners need to work together, strip out some of the technical language and find a way that preserves accuracy, but also expresses reassurance and cites evidence in a way that people who are not scientifically, let alone medically literate, can understand easily and assimilate. Secondly, the range of problems facing governments. I won't repeat what Roger said about the various logistical challenges in Britain and in every other country about getting the vaccines into people's arms, getting the follow-up appointments met and honoured, and then monitoring what impact the vaccines have on individuals. So I simply say I think that health tech has got to be involved here in a big way. And actually, we need to look at the opportunities that digital technology gives us to handle both individual and mass data sets. But I think there are other problems here too. If I was going to just challenge something that Jerome said at the start, it is, I fear, let me put it this way, that the race to get vaccines to your country's populations could turn a lot nastier during 2021. All governments are going to be up against it. They have publics who are demanding the vaccines. They see that they are available now. And they're not going to think very kindly of governments, I think, that so we've got to wait our turn, we can do nothing about it. You see a bit of this in the European Union at the moment, where there's been some kickback in Germany that's happening now, because a decision was taken amongst the 27 that the vaccines would be distributed around every member state of the European Union, whereas Germany did have the wherewithal, the systems in place to have got there earlier, had they chosen to press ahead. And I think Jens Spahn is going to get have a bit of a fight on his hands over that. But what happens, for example, if the United States says that it is going to pass a law that obliges US companies to give priority to the American supply chain when it comes to the manufacture and distribution of vaccines. I just think we have to bear in mind the risk that these things could become more difficult and that the current sort of gentleman's agreement will not last. Then there is the law of diminishing returns. Stafford, you mentioned young people earlier on. My observation, what I see around me in Britain, is that each set of restrictions now meets more quiet resistance. People adapt their behavior and look for ways in which they can adjust to try to meet the rules, but not necessarily to every last letter. And that's partly just reflects the complexity and variety of people's different personal and family circumstances, that no set of rules is going to be able to be tailored to exactly. But in Britain, more than half of people in their 20s are living with their parents. The idea that young people in their 20s were going to be patient for months on end to see nobody except mum and dad and kiss nobody except mum and dad was always struck me as being fanciful in the extreme. There are certain things about human nature that are not going to change. And sometimes I think it's quite easy for those of us who are middle-aged, settled in life. We've probably got, most of us, a reasonable sized place to live in that we're fairly happy with, perhaps a bit of outdoor space, perhaps in a settled relationship. And actually people in their teens, 20s, 30s are in a rather different situation there. And so, again, communications is going to be to the fore here. And I worry about what Roger said about, it might be have a partially normal Christmas next year, because I don't think that's where public expectation is at the moment. And I agree completely with what Roger said about the need for realism, but I also think it's got to be ambitious realism. I think government should be kicking the tires of every card, asking questions about every aspect of the distribution system, both to check it will deliver. I anticipate problems, but also say, why can't you be doing this faster, and really pressing their scientific and medical advisors and the NHS bureaucracy and management to try to deliver things faster and further. Let me finally just say a few words about China. Again, mistrust is a really big issue here. The British Foreign Policy Group, a think tank, published in May this year opinion research that found that 83% of people in Britain saying they did not trust China to act responsibly in the world. Comparators were Iran on 85% mistrust and North Korea on 88%. just to give you an idea of the general picture. YouGov, polling organisation, the start of this year, 63% considered China untrustworthy, 61% worried about its environmental record. More than a third said that they thought Chinese products were substandard, although I bet that third still went out and bought them in large quantities. Interestingly, when the respondents were told that 3 companies, Lenovo, Oppo, and Huawei, were Chinese owned, people revised downwards their levels of trust in those 3 named companies. So I think that if and when it comes to persuading Western state or regional health bodies or private sector retailers and pharmacists that a Chinese vaccine should be used, it will be important not just that the communications is right, but that the evidence is there on which those communications can be based. So the clarity and transparency about regulatory about regulatory checks as to the efficacy and safety of those vaccines. Both public sector health providers and private sector retailers will be putting their reputations on the line when they authorize and distribute vaccines to members of the public who are basically subcontracting trust to those operations. And people also, with regard to China, ask questions about human rights. Have these been tested on unwilling subjects at all? Is China being a bit more open about the origins of COVID? I don't say this as somebody who loathes everything coming out of China. Far from it. I have critical criticisms of China, but I'm in favour of constructive engagement. But I think one has to acknowledge the political reality and also the geopolitics of this, with the United States, European countries worrying about their the security of their strategic supply chains, which would apply to vaccination capacity as much as to information technology. And that needs to be part of the picture that has to be addressed as well. But I think, therefore, that if I would see if Chinese vaccines are there as part of a mixed choice of different vaccines that are available, then I think it becomes much easier to be able to sell the case for that than if such a vaccine were the only one that was being made available, and there'd be a real fear amongst governments of dependence upon a Chinese supplier and ultimately upon the Chinese government and the CCP. I will finish there, Stafford, but my last sentence is the politicians, a lot is at stake here. They all have to get re-elected. The Germans this coming year, the French president in 2022, British government not to 2024. But they will also desperately want to get this right, and they're going to need to be courageous and show leadership and be straight with people, but they will also need to find ways to press for the quickest possible delivery of the maximum number of vaccine doses.
David, what you've said is actually quite alarming and a real wake-up call in many ways. Can I ask you one political thing? Is that, do you actually think that this situation is going to make health inequalities in the UK worse?
I think that is certainly a risk. I think that it is a risk that can be overcome, and I think peer group pressure and role models are quite important here. So, for example, it won't shock me. I've no idea of this case. It won't shock me as if in the Queen's Christmas broadcast she says that she's had a vaccination. I don't think you'll see it happening. But who are the people to whom the most sceptical groups will look and say, well, if they're having it, perhaps it's all right. And it might be sports stars for some. It might be, rock stars, showbiz personalities, soap opera stars for others. But opinion research needs to find out who people will trust. It's not likely to be the minister. It's good for the minister to have a jab, because actually that's saying, hang on, look, he's not just telling us to have it. You know, why isn't he doing it himself? But I think that health inequality risk has really got to be addressed. And you've also got to bear in mind, Stafford, that an awful lot of people spend precious little time thinking about politics. They don't read any newspapers. They don't listen to or watch any broadcast news bulletins. You know, or some, even more, will buy a newspaper for the showbiz or the sport or the gossip. And communicating with those people needs to be done in a different way. And it's role models and peer groups that are part of that. And Roger said, you know, the local GP, if these people are registered with a GP, whom they perhaps do go to for help when the kids are sick or something, then that is a local figure that most people still respect.
Those are really important points. I wonder if I could bring in Rabbi Jonathan Wittenberg, because I'm just wondering whether there's a role for faith leaders to actually encourage vaccination and to have a lead in this area. And I think he's with us. Jonathan, could you actually comment on this?
I'll do my best. This was gripping and extremely helpful. And I just want to emphasize the point which comes up again in the way faith communities share information, which is what was said about the need for an accurate, comprehensible, reassuring and assimilable communication about the process the vaccine has been through and its safety. That will be really invaluable. Even in this secular country, a very large number of people belong to faith communities, and across the world, I think the figure is at around 80%. So there will be a communication role for faith leaders, particularly if one can, and here I would speak, you know, for Judaism, I can't speak for other faiths, link it to precepts of the religion which people respect. For example, in Judaism, it's a basic precept that one does what one can to protect one's own health, and all the more so the health of others. And that is a basic responsibility, and it's a responsibility towards those around us. So the messaging here and the encouragement is something that in which I think faith should have a role.
Oh, thank you very much. I think that's a really important area. Can I just start this? We've had a lot of questions in. Can I just start some of the questions? I'd just like to ask Jerome a question. Is that as the richer countries are having much more access to vaccines, it appears that the newer vaccines that are coming out are going to need to be looking to poorer countries which have no access to vaccines. And there have been comments about vaccine imperialism and things like this. I just wonder if he has a feel for what we should be doing with the newer vaccines which haven't been tested yet.
So I think that there are maybe two different ways to answer the question. The first is there is absolutely a potential that there may be a divide between wealthier nations and poorer ones with regard to the distribution of RNA vaccines, with their differing cold chain requirements that are a little bit beyond what we would normally expect countries, even with sophisticated delivery systems, to handle. The next generation of vaccine, so, and I would include the AstraZeneca vaccine because it hasn't been approved at this point, have storage requirements in the 2 to 8 degrees Celsius range, which is refrigerator temperature. So that would be potentially very useful. The Chinese vaccines, again, as Sir David had mentioned, are actually quite accessible from that perspective also, being 2 to 8 degrees storage. I think that the big issue here will be how quickly the regulatory review of vaccines like the AstraZeneca vaccine, or in the future, Novavax or the Johnson & Johnson adenovirus 26 vaccine, and then can occur. And then also, it's one thing for the regulatory authorities in Russia and China to approve vaccines. They're not considered stringent authorities, so it will require an additional review, probably by a stringent regulatory authority like the MHRA, but probably the EMA, as a way to get into the World Health Organization's pre-qualification system, which is actually going to be very important for countries around the world. And having access to that type of vaccine, I think they call them now the late first wave vaccines, is going to be very critical early on, because I think we've seen companies have been having trouble ramping up production. So the more companies that have vaccines that are safe and efficacious, the more likely we are to have global distribution of vaccines that can be used all over the world.
That's very useful, and that's going to be very important. Do you think that it's going to be possible to carry out these studies in some of these poorer countries? Have they got the infrastructure necessary to actually test these vaccines?
Yes. So it turns out that I guess Brazil is a middle-income country, or an upper middle-income country, but there are vaccine trials now planned for places like the Philippines, planned in Latin America, in Peru. So, and a number of trials going on now in South Africa, which is also not among the poorest countries. One of the problems that we have right now is that there aren't a lot of good data from Africa. The actual reported number of cases in Africa has actually been fairly low, as have been the number of deaths. And so, it's raised some questions. Do we need to vaccinate there at all? But I think it gets to a question about how we detect and report both infections and deaths. And so, Kenya had 60,000 infections reported. When they look at national blood bank data, so this is all over Kenya, 5% of Kenyans have been infected, which is close to 2.5 million. So there may be a testing and reporting dislink. And then also death registries are not, need to be augmented in many countries. Not all countries accurately record all the deaths that occur. So again, South Africa reports, a fairly large number of deaths, but when you look at excess deaths, the number may actually be 60% higher. So again, we do have to work on understanding where the disease is so that we can see if the vaccines are actually going to be helping and working.
So in terms of our discussions, and this is one for all of you, it's the relationship of the economics to the healthcare bit. We have Ray Gelato here, who I would like to bring in on this, because he's a well-known jazz player for whom all the changes that have been happening have been absolutely disastrous. And Ray, would you just like to tell us a bit about this?
Sure. Well, first and foremost, without going into too much, I found this whole thing fascinating, and reaffirming my belief how serious it is, because we like to sometimes in our world, feel quite victimized by what's going on, because we've suffered quite a lot, all of us. But it's been more than tough. I mean, we've had thousands and thousands of pounds of work cancelled all year, and most of my work is abroad. Really, Spain and Italy is where I mostly work, apart from the UK. It's difficult to know what to say after hearing this, because it's an extremely serious thing, and it seems like a long road back, to really claw back what's going on. And that's not just for me, that's for theatres and all this. I mean, we were just about to do Ronnie Scott's starting last Friday, and that was cancelled, which I was very upset about. But then when they cancelled everything, it made me feel a little bit better. So we didn't feel kind of the entertainment industry wasn't really singled out. It was a good reason for doing so.
Okay, well, I'm certainly looking forward to you getting back and being able to work again so that we can listen to you. Can I just end it with, well, not end it necessarily, but there's a question from Liz Miller, which with only slightly tongue-in-cheek, which was that should politicians be expected to have a GCSE in science as a minimum qualification for office, to include logic, epidemiological modeling, DNA and viruses? It's really a question for David in a way, is, the interaction between scientists and politicians. And for people outside, this has been very difficult to actually understand whether they're speaking the same language, whether they're talking to each other. This idea of following the science, which seemed to work to begin with, or people seem to understand, seems to have been totally lost. And you know, is there a way we can get back so that the public actually will believe that the politicians understand the science and are using it in the most effective way?
I mean, Stafford, I mean, my straight answer is no to the question. You know, the electorate is entitled to elect whoever they want to elect, you know, whether they're qualified or not. That, you know, elective politics is the only the only thing in our society where you don't need any qualifications at all. But like, you know, the electorate had to have that freedom. But I do think that there should be better induction and a better sort of in-house training for elected members of parliament, members of devolved parliaments, and perhaps even local councillors, on, certainly for metro mayors, on statistics, on risk, on some of the key scientific elements. There is stuff there. I mean, there's a very good Parliamentary Office of Science and Technology, but you have to go and find it and sort of ask for briefings and so on. But I also think we need to do more as a society to use the very gifted communicators that we already have. If you look at people like Brian Cox on astronomy, Tim Harford on anything statistical, David Spiegelhalter made a real reputation for himself recently, Jim Al-Khalili, Jonathan Van Tam this year has become a well-known sort of household figure. I mean, an impersonator could now take off JVT and everybody would know who he intended. Or, you know, the doyen of them all, Sir David Attenborough, who conveys really powerful, complex scientific truths in very accessible language and images. And I think it's trying to find more people like that, but then also for politicians, it's trying to work out how to convey some of those scientific and statistical realities in in accessible terms, which are also believable. Because sometimes, you know, if no one is going to believe me if I stand up and pronounce as if I were some expert scientist, but I should be able to stand up and say, look, simple language, this is what the scientists are telling me, and follow that link if you want to go and look at the detail. And I think that is something that politicians need to do. And I agree, I do go back to what Roger said as well. I do think that particularly in a crisis like this, I think it is essential that people in positions of leadership are straight with people, and that includes being straight about uncertainty. I think governments have got themselves into a mess where they've pretended to certainty and they've been reluctant to publish evidence and actually say, look, this is what we have so far, and we're having to take decisions on the basis. I actually think one of the ironies of COVID is that there has been a huge willingness amongst publics to give their leaders the benefit of the doubt. And actually say, you know, and the number of people who stopped me in the street and said, look, I may think sometimes the government's making a complete mess of things, but actually I'm not sure anybody could have done much better, because this is a completely unknown disease, and I wouldn't like to be taking those decisions. But actually that reinforces the need for ministers to be candid, admit to uncertainty, which no politician likes to do.
Okay, well,
sorry,
Roger, please, yes.
Yeah, very quickly, if I may, very quick anecdote to follow that. At the weekend, I was talking to an extremely sensible young man in his early to mid-20s, after the Prime Minister had given his latest lockdown essential briefing. And I said, that feels, for the first time, that feels like it felt on the very first announcement in March. And he said, no, it didn't. And I said, why not? He said, because in March there was trust. And he said, that has gone. And you can't that horse has bolted, you cannot catch that horse now. And I think one of the reasons why someone like Nicola Sturgeon irrespective of politics, has got a better personal profile in terms of competence than Boris Johnson is purely down to her day in, day out, being straight, being the only person at the lectern, no one else, telling it like it is. And you get people saying, well, she's doing her best. And to some extent, that's all you can really hope for, as David alluded to. If you've got the public saying, well, they're doing their best, they'll put up with an awful lot. What they won't put up with is over-promising and underachieving.
And this has been a fantastic webinar, it really has, but the very last thing I'd like to do is to ask, in fact, this is a letter from a question from Lynn Russell, and this is a question I'd like to put to each of the panelists, which is, how and when do you honestly see our world getting back to how it was before COVID? Let's start with Jerome, Jerome.
Okay, actually, can I just quickly on what Roger and Sir David have been saying? The WHO actually had looked into the problem of around vaccine hesitancy and access, so enabling access to care and generating social supports for this are really going to be key to and leading with science are really going to be key to putting things in place. So when will we be out of this? I think that 2021 will be an important year. If we can get enough vaccine out and if we can convince people that at least in the beginning, they're going to need to continue to protect themselves and others by using masks and distancing and avoiding crowds, I would guess that the end of 2021 to 2022 are probably going to be in higher income countries where significant rollout of vaccine will occur. Other places could be longer.
Roger?
Depends what you mean by out of it. In terms of people going about their daily business, feeling relatively normal, I suspect 18 to 24 months. But the trouble is COVID is going to continue to circulate around the globe pretty much forever, and it's going to continue mutating. COVID is going to become part of our daily lives. It will rise and it will fall. We're going to have probably further outbreaks across the globe, even once we've dampened this one down. So we will learn to live with it. But COVID is now a word we are always going to be using.
And David, can I change the question very slightly for you? Is that, well, basically, do you think politics will ever be the same again?
Well, politics never does stand still. So no with that, but it will be unpredictable. And you know, it probably, COVID may well have cost Donald Trump the American presidency. If you look at how the 2020 panned out electorally in the States, it could finish Boris Johnson, the Conservative Party's reputation, or it could, by 2024, be that it seemed to have been, in retrospect, been handled, you know, not much better, not much worse than other comparable countries were doing. So, I mean, I think the crucial factor is how quickly you get to vaccinating the over 80s and the over 70s, because, you know, what I read is that 90% of deaths can be avoided once you've vaccinated the over 80s, and 99% roughly once you've got 95 plus once you've got to the over 70s as well. At that stage, I think the pressure to manage this, with all the caveats Roger said about COVID still being there mutating, like influenza, it is something we will have to learn to live with in that sense. But if it is not carrying the same risks of overwhelming intensive care units, of disproportionate numbers of deaths, then I think people look at it very differently.
Well, thank you very much. I'd like to thank all of our panelists very much indeed. And I'd just like to pass over to finalize. I can't see him. Where have you gone to?
I'm here.
Oh, you're here. So would you like to finalize and bring everything back together and help Ray finish this all off?
Well, we will never finish this all off. Look, first of all, Stafford and Sanjeev, I would just like to thank you both for being two brilliant colleagues over the last 8 months. Working with you both over this period of time has helped me deal with the unknown. meeting you both on Zoom, planning all the things that we've done, meeting all the incredible people that we've met. You know, the chutzpah, as Sanjeev, you and I have, of connecting with people who don't even know us. People like David and Jerome, who've been magnificent. For many people who don't know, Jerome, what time is it now in Seoul, Jerome?
20 after 6 in the
So
morning.
you always wear a nice suit at that time in the morning, do you?
I sleep in it's from my medical training.
You were the most elegant virologist I've ever met. I was taught virology by Don Jeffries, who was lovely, but I don't think he knew what a tie was. And his pipe stuff went all over him the whole time. Jonathan, thank you for joining us. David, thank you for your honesty about politics. That was a big thing to talk in the way that you've done. Look, we've had some great speakers over the last 9 months. And of course, the one thing the world didn't know is, what do Jerome Kim and Ray Gelato have in common? And they have tonight. So now I'm going to hand you over to Ray Gelato. Now, before I do, I discovered that many years ago, I actually got on stage with Ray Gelato at the Barts Hospital Summer Ball when he was in the Chevalier Brothers. But Ray Gelato played on a webinar in the summer about lockdown. And Ray Gelato is back here tonight. We are delighted he's with us tonight, but we're also not delighted he's with us tonight because he was due to be on stage doing his Christmas show, bang now, 9:30 at Ronnie Scott's. And I actually had tickets for the Saturday night show. So Ray, I'm really, really sorry that you're here with us. But I'm delighted that you're going to play us out. So Sapien Care will be back again. I'd like to thank all the wise men and women who've been with us tonight. Claire, thank you for your hosting. Thank you everybody who's been on the webinar with us. Roger, thank you for being the doctor, which is terribly important. And Stafford, thank you for being our Jim Al-Khalili. So Ray, we hand over to you now. We're all going to go very quiet, and thank you everyone who's attended for being with us tonight. Thank you all. And I wish you a safe Christmas and a very much better 2021. We leave you with Mr. Ray Gelato.
A song I wrote called Is Santa Claus Real? I wrote it for my little girl, and I hope you like it. Merry Christmas, everybody, and let's wait for better times. Round about Christmas time, there lived a little girl so fine. This little girl, she loved Christmas every year. But when the snow would fall and Christmas trees grew tall, she'd sit and wait for Santa Claus to appear. Oh, when one day at school, some of the kids were cruel. They said Santa and his reindeer were not true. Her daddy sat her on his knee, then explained patiently, tonight, little baby, Santa Claus is coming to you. And then she said, is Santa Claus real? Is Santa Claus real? Listen, little children, on Santa's on his way. Is Santa Claus real? Is Santa Claus real? Santa's got lots of toys for all your little girls and boys, as he waved goodbye as his reindeer pulled his sleigh. Thank you.
So listen, thank you all very much for being with us in 2020. Sanjeev, Stafford, I and Roger will be back in 2021. We'll be planning our webinars, but I'd like to thank everybody who's taken part, both attendees and panelists over the last 9 months. And Stafford and Sanjeev, it's been an absolute honor and privilege to work with you both. So I wish you all a very good Christmas, New Year. And Sanjeev, I hope you feel better tomorrow. Thank you for coming on. Good night, everybody. Bye.
Good night.
Thank you all.
Thanks, Nick.